Welcome back. We're now in Chapter 4, Part 1 in our video series on how to interpret 12-lead EKGs. In this video, we're going to get a chance to practice our systematic approach to rhythm interpretation. So let's get started. Okay, take a look at this strip and let's go through our process. First thing I need to do is determine the rate. Okay, this is pretty simple. Got 30 beats per minute. Is it regular? It is regular. Do I have a P wave before every QRS and only one P wave before every QRS? I do, so that makes it normal. Is my PR interval normal? Yes. QRS duration normal? Yes. Interpretation, sinus bradycardia. That's a look at sinus bradycardia. As you recall from the other video, we talked about this is just a problem within the SA node itself. It's firing too slowly. Okay, rhythm number 2. Let's do the same thing. First of all, let's determine the rate. 130 beats per minute. Is it regular? Yes, it is. Do I have a P wave before every QRS complex and only one P wave before every QRS complex? Yes, I do. PR interval, does it look good? Yes. My QRS duration looks fine. So interpretation, sinus tachycardia. Same thing, problem within the SA node, it's just firing too soon. This is often attributed to physical or psychological stress. It's not a primary arrhythmia, and one of the most likely causes of sinus tachycardia is dehydration. A lot of times you'll have a patient and they give them some fluids and they return right back to normal sinus rhythm. Okay, we're going to take a look at some other strips. All right, take a look at this and look at your rate. 70 beats per minute. Is it regular? No, not regular. All right, my P waves. Well, 2 of them are different than the others. There they are. So my PR interval is off on a couple of them. My QRS duration stayed the same. It was normal. So interpretation is normal sinus rhythm with premature atrial contractions. And there they are. And these are just atopic beats that occur within the atrium, not originated from the sinus node, but still the atrium. But they did, however, send the electrical conduction down the normal pathway. Okay, and when looking at that, you can see that, look at this slide, the QRS has remained within normal limits. They stayed within 1 to 3 boxes. So despite the fact that the atrium contracted, caused an impulse that made it contract too soon, the ventricle couldn't tell the difference. It remained normal. So you did not lose any cardiac output because you're from the ventricle side. So premature atrial contractions are really no cause for concern most of the time. So they can lead to, AFib down the line, but, if you just see occasional premature atrial contractions, that's not typically treated. Okay. Let's look at our rate. Okay, 60 beats per minute. Is it regular? It's occasionally irregular. Look at my P waves. Do not have a P wave before the last QRS. So my PR interval is normal up until that point. And my QRS duration is too wide on the last beat. So by definition, this is sinus rhythm with 1 PVC. Okay? And this is quite similar to what goes on in the atrium. You have an atopic beat that originates in the ventricle, and it results in a wide, bizarre, and ugly QRS complex. When there's more than one, you know, it's multiform. If you have more than, if it's looks different. In other words, the same rules apply when we look at P waves to determine, you know, did they look alike with other P waves? That lets us know that it came from the same. Remember I told you in the last video, they're like, waves are like fingerprints. Well, same thing goes on in the ventricle. So if you had two PVCs occur in the strip and they weren't identical, then they were coming from two different areas that were irritated within the ventricle. And that would definitely raise a little more concern than if we just had one occur, or one of the same type occur every so often. Okay? So this demonstrates the fact that I can tell right away that I have two PVCs, and I know that because the ventricles are too wide, for one thing, on both of these beats, but also I can tell that they could not have came from the same focus because one is upside down and the other one is upright. And that really has to do with, if you've ever wondered why some waves are upside down, when we are looking at lead 2 consists of two electrodes. The negative electrode is put on the patient toward the right limb, the right arm. And the positive electrode is going to be down toward the left leg. And so in normal conduction, the impulse is going to move toward the positive lead, always. And due to the location of where lead 2 is placed, and it's looking at the inferior wall of the heart, what happens is, as the electricity moves down toward the positive lead, then the positive lead, in turn, when it receives that signal, is like a camera that looks back up toward the direction of the negative lead, and that's what ends up being on the tracing on our EKG paper. So, good way to remember that is when we're looking, since lead 2 is the reference lead, we're looking at lead 2 when you look at your patient. Normal impulse should move from, I like to think of it, it's northwest to southeast, so I like to think of states, and the impulse should be going from Oregon to Florida. Okay, so if the impulse here, I know electrical impulse is moving from Oregon and heading toward Florida. Okay, and as I go along this EKG strip, and I go here, and I have this premature ventricular contraction, this wave is upside down. And so what that tells me is that at this point right here, when that focus in the ventricle fired, it did so retrograde. It went back the other way because this is below the isoelectric line, and that does not follow the definition of normal conduction. So if you ever wondered why waves flip, that's exactly what happens. So we're going to have a visual depiction of that coming up, but that's just going over what I just explained. Just looking at that one. They're wide, ugly, and bizarre. Okay. So normally when the signal moves rapidly through the ventricles, you see it's going toward the negative, it's going from the negative lead toward the positive lead, which would be the patient's left side. Okay. Now, abnormal conduction occurs slowly. And also, can you see that if the abnormal early beat originated here, it's going toward Oregon, so it's going toward the negative lead. This is why this is where you would have an upside down QRS complex if that occurred. If it was here and it moved toward normal conduction, you would still have a PVC, but it would be upright. So that explains why you have waves that are sometimes upside down. So that's enough for now. Hope you have a good day. Thank you.